Hello, so today I will be presenting my mid-semester clinical case report based on a patient that I cared for during my clinical shift. So my patient was is a 70-year-old female with a history of BRCA2 mutation and duodenal adenoma, who was post-operative day 6 following a robotic duodenal mass resection and cholecystectomy with intraoperative cholangiogram. The focus of her hospitalization was post-operative recovery, monitoring for complications, pain management, nutritional support, and evaluation of possible intra-abdominal leak. So, background and current status of the patient. During my shift, the patient remained NPO except for medications and was recovering through TPN through a PICC line for nutritional support due to delayed return of bowel function. Neurologically, the patient was alerted and oriented ×4, cooperative and able to communicate needs effectively. She had a JP drain with serum sanguineous output, which required close monitoring for signs of infection or leakage. During the mid of my shift, she did an output of 15 milliliters of serum sanguineous output. The morning vital signs for her were temperature of 100.6, blood pressure of 38.59, heart rate of 92, respirations of 18, and oxygenation of 93 room air. These findings suggested mild fever, borderline oxygenation, and it raised concerns for postoperative inflammatory and infectious process. So some subjective cues that I recognized during my assessment were abdominal pain and gas discomfort, no bowel movement or passing of gas, post-operative fatigue, as well as the high WBC of 14.6, potassium, which was low at 2.8, phosphorus, which was a 9.6, glucose was a 174, and calcium was a 8.0. Imaging also showed fluid near the surgical site, and it raised concern for acute leak. Additional relevant assessment cues were that GPA drain, the PICC line, the NPO, the recovering of IV antibiotics or the receiving of IV antibiotics, and the PCA for pain control. So when I analyzed my cues and did my priority hypothesis, I concluded that my priority problem was infection related to the possible intra-abdominal leak. The infection was concluded because of the high WBC count of that 14.6 and the borderline fevers that the patient kept getting. There was also that fluid near the surgical site on the CT scan and the presence of the invasive devices and the recent GI surgery and the nutritional compromise due to the NPO status. With that, I used the theory of the ABCs, which indicated that infection was prioritized due to the potential progression of sepsis and impaired physiological instability. So the SMART goal that I created for this patient was that the patient will demonstrate improved infection status as evidenced by decreasing trend of the WBC, absence of fever, and stable JP drainage as evidenced by lower WBC, a temperature under 38.0 degrees Celsius, and no abnormal sanguineous JP drainage of the site. Some nursing interventions that I did for this patient were to monitor infection indicators. So I monitored temperature trends, WBC levels, and JP drain output and characteristics. These findings serve as early indicators of infection or leak around rapid and allow for rapid intervention and prevention of sepsis. I also administered IV antibiotics like Zosyn as prescribed. So, broad spectrum antibiotics reduce bacterial proliferation and prevention of systemic infection associated with intra-abdominal complications. Maintaining sterile technique with PICC line and JP drainage was another intervention that I did. I used aseptic technique during medication administration and line care. Invasive, this rationale was that invasive devices increase infection risk, and a sterile technique prevents catheter-related bloodstream infections. The fourth intervention was to encourage mobility and pulmonary hygiene. So I encouraged the patient to use her incentive spirometer and early ambulation. This allows for mobility to improve circulation, immune response, oxygenation, and GI motility, and it reduces post-operative complications. The fifth intervention that I did was to monitor electrolytes and assisting with replacement. So I monitored that potassium, that phosphorate, and that calcium levels, and supported the replacement of that therapy by administering that potassium every hour as scheduled. So the replacement of electrolyte imbalances can impair cardiac or electrolyte. The rationale for this intervention is that electrolyte imbalances can impair cardiac function, GI motility, and healing. Making corrections is essential for recovery. So the sixth intervention was providing pain management. So even though as students we are not allowed to adjust or replace PCA pumps, I still supported my patients' pain management and control measurements by letting my instructor and nurse know whenever the PCI syringe needed to be changed, or by assessing my patient's pain control after hitting each button and evaluating if her pain has improved or not. And the rationale with this is that effective pain control promotes mobility as well as deep breathing and participation in recovery and thus reducing complications. So at the end of my shift, the patient's condition was in progress, as evidenced by still having to use antibiotics because the WCB count was still in the high levels at 14.0, and there was also a need for repeated imaging that was planned, and she was scheduled to go to, and although her temperature did decrease with the use of antipyretics, the goal was still not fully met and remained in progress at the end of my shift. Some recommendations that I would do to continue to help accomplish or meet this goal would be to still continue to administer those antibiotics at scheduled time. Prepare the patient for that CT scan by giving the iodine CT contrast, and then after that, waiting for those CT records to come back and analyzing if the patient is still currently leaking fluid and if the patient might have to prepare for another procedure to close that leakage. So the application of course content, this clinical experience allowed me to apply previous knowledge from courses like pathophysiology that helped understand post-operative complications like infection, and recognizing those early cues, as well as pharmacology by the use of those antibiotic and electrolyte replacements. as well as med-surg nursing, like drain management and post-operative care. And then also just by levels 1, 2, and 3, further utilizing that clinical judgment module by helping me prioritize my client's number one priority and clue recognition. A major area of growth during this clinical experience was medication administration confidence. With my clinical instructor, I was able to safely perform IV push medication administration to a PICC line, as well as doing piggyback medication administration with those antibiotics. And this experience strengthened my understanding of medication compatibility, infusion safety, aseptic technique, and monitoring for adverse reactions. It significantly improved my confidence in medication administration and reinforced safe practice principles. Areas of improvement would be to strengthen interpretation of post-operative imaging. So when reviewing background of these patients, you also want to go look at images, CT scans, things like that, just to help you further understand those images as well. And then increasing confidence with drain management, since this was my first JP drain, and since all the levels, although I was successful at taking care of them and draining them and analyzing them, I could improve on just being more familiar with it as well. And also enhancing interdisciplinary communication. On the nursing orders, there were orders for nurses to report temperature higher than 100.4, which I was able to report to my nurse, and then the nurse and I were able to report that to the provider. And this was reported through the nurse's secure chat. So I would like to improve on having more confidence to just reporting it to the provider myself, since I will be the one who has to do it when I do become a nurse and take care of these patients by myself. So in conclusion, overall, this clinical experience enhanced my clinical judgment, prioritizing skills, and medication administration with confidence while caring for a complex post-op patient that has infection. Thank you.